Here is a question that most adults over 60 cannot answer, even though it is one of the most important numbers in their health profile. What is your blood pressure supposed to be? Not what it currently is. Not what your doctor has been trying to get it to. What it is actually supposed to be for a person of your age, your cardiovascular history, your kidney function, and your physical condition. If you answered 120/80, you are repeating a number that was established in research conducted primarily on younger adults, and that has been applied to older populations without adequate justification for decades. If you answered 140/90, you are using the older guideline threshold that was standard for adults over 60 until relatively recently. If you answered 130/80, you are using the 2017 American College of Cardiology guideline that lowered the definition of hypertension, a change that instantly classified millions of previously normal older adults as hypertensive, and that remains one of the most debated decisions in recent cardiovascular medicine. The real truth that the research supports and that most patients are never clearly told, is that the optimal blood pressure for older adults is not a single fixed number. It is a range. It is individualized. It changes depending on your age, your frailty status, your medication burden, and your overall health trajectory. And the history of how we arrived at our current guidelines is a story of dramatically shifting scientific consensus that should make every adult over 60 want to ask far more specific questions than most are currently asking. That is what today's video is about. The history of blood pressure management in older adults is, in many ways, a history of medicine learning from its mistakes. For most of the 20th century, elevated blood pressure in older adults was considered an acceptable, even necessary, adaptation to aging. The prevailing view was that higher blood pressure in older people reflected the arterial stiffening of aging, and that the heart needed that higher pressure to adequately perfuse organs through stiffer, less compliant vessels. Treating it aggressively, the thinking went, would do more harm than good. This view began to shift with landmark trials in the 1980s and 1990s. The SHEP trial, the HYVET trial, which demonstrated that treating isolated systolic hypertension in older adults reduced stroke risk significantly. These trials established treatment as beneficial and shifted the consensus toward active management. Then came the debate about targets. How low should blood pressure go? The answer seemed obvious. Lower is better. The lower your blood pressure, the less strain on your arteries, the lower your risk of cardiovascular events. This logic was intuitive, widely accepted, and, as subsequent research would reveal, incomplete. The ACCORD trial, examining aggressive blood pressure lowering in diabetic patients, found no cardiovascular benefit from systolic targets below 120 millimeters of mercury compared to targets below 140 millimeters of mercury. The SPRINT trial, published in 2015, appeared to contradict this, finding significant cardiovascular benefit from intensive blood pressure lowering to below 120 millimeters of mercury systolic in high-risk non-diabetic adults. SPRINT became one of the most influential studies in cardiovascular medicine, driving the 2017 ACC/HA guideline change that lowered hypertension thresholds dramatically. But SPRINT had features that are critical to understanding its applicability to the broader population of older adults, features that were not prominently communicated when the guideline change was announced. The blood pressure measurements in SPRINT used an automated, unattended protocol that produces readings approximately 5 to 10 millimeters of mercury lower than conventional clinic measurements. This means that SPRINT's 120 millimeters of mercury target corresponds to approximately 130 to 135 millimeters of mercury in conventional clinical measurement, a nuance with profound implications for how aggressively millions of older patients are now being treated. The National Institute for Health and Care Excellence in the United Kingdom, one of the most rigorous evidence-reviewing bodies in medicine, has maintained a higher blood pressure threshold for adults over 80, recommending treatment initiation at 150 millimeters of mercury systolic rather than the 130 millimeters of mercury threshold advocated by American guidelines, reflecting a more cautious interpretation of the same evidence base. The American Geriatric Society has published explicit guidance recommending against targeting blood pressure below 130 millimeters of mercury systolic in adults over 65 who are frail or have significant comorbidities, noting that the harms of aggressive treatment in this population are real, consistent, and underweight in guideline development. The National Institute on Aging has funded research specifically examining the relationship between blood pressure, brain health, and mortality in the oldest old, adults over 80, and has found evidence that in this age group, blood pressure that would be classified as hypertensive by current American guidelines may actually be associated with better cognitive outcomes and lower all-cause mortality than blood pressure in the normal range. This is not a settled debate. It is an active, ongoing scientific conversation in which the evidence is genuinely complex, and in which the default application of young adult blood pressure targets to older bodies is a practice that the most rigorous geriatric medicine research consistently questions. Today I am going to walk you through what the major trials actually show, what the evidence says about the optimal blood pressure for older adults, and give you the specific questions you deserve to be asking at your next physician appointment. Leave your age and your current blood pressure target in the comments. Has your doctor told you what number they are aiming for and why? Most people have never been given a specific explanation. Let's find out what the research actually says. Let's get into the evidence. I want to frame this section carefully. Blood pressure management is one of the most studied areas in all of medicine, and the volume of research is matched only by the complexity of its conclusions. What I am going to share with you is not my personal opinion about what your blood pressure should be. It is an honest account of what the major clinical trials found, what the guidelines say and why they disagree, and what the research specifically tells us about blood pressure in different subgroups of older adults. The goal of this section is to give you a framework, a set of specific, research-grounded reference points that allows you to have a more informed conversation with your physician than most patients are currently equipped to have. Let's go through the evidence. The SPRINT trial. What it actually found. The Systolic Blood Pressure Intervention Trial, SPRINT, enrolled 9,361 adults aged 50 and over with systolic blood pressure between 130 and 180 millimeters of mercury and at least one cardiovascular risk factor. It randomized participants to either intensive treatment targeting systolic blood pressure below 120 millimeters of mercury or standard treatment targeting below 140 millimeters of mercury. The trial was stopped early, after approximately 3.3 years of follow-up, because the intensive treatment group showed a significant reduction in major cardiovascular events and all-cause mortality. What it actually found. The intensive treatment group had a 25% relative reduction in major cardiovascular events and a 27% reduction in all-cause mortality, findings that were statistically significant and clinically meaningful. What most people were not told. First, the blood pressure measurement protocol in SPRINT used automated office blood pressure measurement, taken without a healthcare provider present, after 5 minutes of quiet rest, averaged over 3 readings. This protocol consistently produces readings 5 to 10 millimeters of mercury lower than conventional clinic measurements made in the presence of a healthcare provider. When this correction is applied, SPRINT's 120 millimeters of mercury intensive target corresponds to approximately 130 millimeters of mercury in conventional clinical measurement, and SPRINT's 140 millimeters of mercury standard target corresponds to approximately 150 millimeters of mercury. In other words, SPRINT may have been comparing a 130 millimeters of mercury target to a 150 millimeters of mercury target, not 120 to 140 as reported. Second, SPRINT excluded several important patient groups, including adults with diabetes, adults with prior stroke, and adults living in nursing homes. These are precisely the subgroups in whom the risk-benefit calculation of aggressive blood pressure lowering is most uncertain and most contentious. Third, the intensive treatment group experienced significantly higher rates of serious adverse events, including acute kidney injury, electrolyte abnormalities, and hypotension, with syncope occurring at nearly twice the rate of the standard treatment group. Falls and fall-related injuries were numerically higher in the intensive group, though not statistically significant in the trial. The ACCORD trial, the contradiction, what it found. The action to control cardiovascular risk in diabetes trial, ACCORD, examined intensive blood pressure lowering in adults with type 2 diabetes, targeting systolic blood pressure below 120 millimeters of mercury versus below 140 millimeters of mercury. Unlike SPRINT, ACCORD found no significant reduction in the primary cardiovascular outcome with intensive treatment, despite producing equivalent blood pressure reductions. It did find a significant reduction in stroke with intensive treatment, but this was offset by a higher rate of serious adverse events, including hypotension, electrolyte disturbances, and kidney function decline. Why the SPRINT and ACCORD findings differ? The contradiction between SPRINT and ACCORD is partly explained by the different patient populations. ACCORD enrolled exclusively diabetic adults, SPRINT excluded them. But the more fundamental lesson is that aggressive blood pressure lowering does not produce uniform benefit across different patient subgroups, a finding with profound implications for how blood pressure targets should be individualized rather than universally applied. The HYVET trial, the oldest old, what it was, the hypertension in the very elderly trial. HYVET specifically examined blood pressure treatment in adults over 80, the population most frequently excluded from major cardiovascular trials and about whom the least specific evidence existed. It enrolled 3,845 adults over 80 with sustained systolic blood pressure above 160 millimeters of mercury and randomized them to treatment targeting below 150 millimeters of mercury systolic or to placebo. What it found? HYVET found significant reductions in stroke, heart failure, and all-cause mortality with treatment. The target, below 150 millimeters of mercury systolic, was notably higher than the targets advocated in trials of younger populations. And the benefits were clear and significant even in this oldest patient group. What it tells us about blood pressure targets after 80. HYVET established that treatment is beneficial even in the very elderly, but with a target of 150 millimeters of mercury systolic, not the 130 millimeters of mercury or lower advocated by more aggressive guideline frameworks. NICE guidelines, based in part on HYVET, currently recommend a clinic blood pressure target of 150 millimeters of mercury systolic for adults over 80. This is a fundamentally different treatment standard from the 130 millimeters of mercury target of the 2017 ACC/HA guidelines. And the difference between these two standards translates to millions of older adults receiving more aggressive medication than the evidence for their specific age group supports. The frailty dimension, why physiological age matters more than calendar age, the evidence on frailty and blood pressure. One of the most important and most consistently overlooked dimensions of blood pressure management in older adults is frailty, the clinical syndrome of reduced physiological reserve characterized by weakness, slow walking speed, exhaustion, low activity, and unintentional weight loss. Frailty profoundly changes the risk-benefit calculation of blood pressure treatment. Research published in the Journal of the American Medical Association Internal Medicine found that in frail older adults, intensive blood pressure lowering was associated with increased mortality, the opposite of the benefit seen in non-frail adults in trials like SPRINT. The mechanism appears to be orthostatic hypotension, the dangerous drop in blood pressure upon standing that is far more common and more severe in frail older adults, which increases fall risk, syncope, and the cardiovascular consequences of hypotensive episodes. A landmark analysis published in The Lancet, the SPRINT-MIND substudy, found that while intensive blood pressure lowering reduced mild cognitive impairment risk, it did not significantly reduce dementia incidence, the outcome that most older adults would identify as their primary cognitive concern. The European Society of Hypertension 2023 guidelines introduced a specific frailty-based stratification for blood pressure targets, recommending that frail older adults maintain systolic blood pressure between 140 and 150 millimeters of mercury rather than the lower targets recommended for non-frail adults, explicitly acknowledging that a single numerical target is inappropriate for the heterogeneous population of adults over 65. The J-curve, when lower is not better. What the J-curve is, the J-curve phenomenon, one of the most debated topics in hypertension research, refers to the observation that the relationship between diastolic blood pressure and cardiovascular outcomes follows a J-shaped curve rather than a linear one. As diastolic blood pressure falls below approximately 70 millimeters of mercury, which can occur in older adults with isolated systolic hypertension when systolic pressure is treated aggressively, cardiovascular event risk begins to increase rather than decrease. The physiological basis for the J-curve is coronary perfusion. Unlike other organs, the heart muscle receives the majority of its blood supply during diastole, the relaxation phase of the cardiac cycle. When diastolic pressure is too low, coronary perfusion is reduced, and in older adults with any degree of coronary artery disease, this reduction in diastolic coronary filling can produce myocardial ischemia. Aggressive treatment of systolic hypertension in older adults frequently drives diastolic pressure below the safe threshold, creating the paradox of treatment that improves systolic pressure at the cost of diastolic compromise. Research published in the European Heart Journal found that diastolic blood pressure below 70 millimeters of mercury was associated with significantly increased risk of cardiovascular events in adults with treated hypertension, with the excess risk concentrated in older adults and those with established coronary artery disease. What the evidence supports. A practical framework, taking all of the evidence together, the SPRINT trial and its measurement caveats, the ACCORD findings, the HYVET data for adults over 80, the Frailty research, and the J-curve phenomenon. Here is the framework that the most carefully considered interpretation of the evidence supports. For adults aged 60 to 79 who are not frail and have no significant comorbidities, a systolic blood pressure target of 130 to 139 millimeters of mercury is supported by the evidence, noting that this corresponds to approximately 120 to 130 millimeters of mercury by the automated measurement protocol used in SPRINT. This is broadly consistent with current ACC/AHA guidance for this subgroup. For adults aged 60 to 79 who are frail or have significant comorbidities, a systolic target of 140 to 150 millimeters of mercury is supported by the evidence, and the European Society of Hypertension guidelines specifically recommend this range. Aggressive treatment targeting below 130 millimeters of mercury in this population is not supported by the available evidence and may cause harm. For adults over 80, a systolic target of 140 to 150 millimeters of mercury is specifically supported by HYVET, the only major trial conducted exclusively in this age group. Treatment is beneficial at this target. Evidence for benefit from more intensive treatment, targeting below 130 millimeters of mercury in this age group is not established. For all older adults, diastolic blood pressure should be monitored carefully and treatment adjusted if diastolic falls below 70 millimeters of mercury, particularly in those with known or suspected coronary artery disease. The J-curve risk is real and should be factored into treatment intensity decisions. The measurement protocol matters. If your clinic blood pressure is being used to guide treatment decisions, ask whether the measurement follows the automated unattended protocol that produces lower readings or the conventional attended protocol. The difference of 5 to 10 millimeters of mercury can determine whether you are at or above a treatment target, and it is a difference that most patients are never informed about. What to do? 5 questions to ask your doctor. Question 1. What is my specific blood pressure target, and why was that number chosen for me? Your target should be individualized, based on your age, frailty status, comorbidities, and medication tolerance. A generic target applied without reference to your specific health profile is not optimal care. Ask for the specific number and the specific rationale. Question 2. How was my blood pressure measured? And is the measurement method consistent with the trials my treatment is based on? The measurement protocol matters enormously. If your clinic blood pressure is taken in a rushed appointment setting without adequate rest by a clinician whose presence elevates your reading through white coat effect, the number driving your treatment may be artificially elevated. Ask for home blood pressure monitoring, the gold standard for treatment decision-making, and discuss whether your readings at home align with your clinic readings. Question 3. What is my diastolic blood pressure, and is it above 70 millimeters of mercury? Many patients know their systolic number, but not their diastolic. Ask for both, and ask specifically whether your diastolic reading has ever fallen below 70 millimeters of mercury on your current medication regimen. If it has, discuss with your physician whether treatment intensity should be adjusted. Question 4. Has my frailty status been formally assessed, and does it affect my blood pressure target? Standard clinical encounters rarely include formal frailty assessment, but frailty status is one of the most important determinants of whether intensive blood pressure treatment produces benefit or harm in older adults. Ask for a frailty assessment and ask how the result affects your treatment target. Question 5. Am I experiencing any symptoms that might indicate overtreatment? Dizziness upon standing, lightheadedness, falls, fatigue, and reduced exercise tolerance can all be symptoms of blood pressure that has been lowered beyond what your body can safely accommodate. If you experience any of these, report them specifically as potential overtreatment symptoms rather than unrelated complaints. The history of blood pressure guidelines is a history of medicine doing its best with incomplete evidence, adjusting, correcting, and refining its recommendations as new research accumulates. That process of refinement is how science is supposed to work. But for the individual patient sitting in a physician's office, being told their blood pressure of 135 millimeters of mercury is now hypertensive and requires medication based on a guideline change that reclassified millions of people overnight. The complexity of that evidence base is invisible. They hear, your blood pressure is too high. They receive a prescription. They go home. The gap between the complexity of the evidence and the simplicity of the clinical encounter is where most of the important nuance disappears. And for adults over 60, in whom the risk-benefit calculation of blood pressure treatment is most context-dependent, most age-specific, and most inadequately served by universal numerical targets, that gap matters enormously. You now have the evidence. You have the framework. You have the 5 questions. Use them at your next appointment. On behalf of yourself and everyone in your family over 60 whose blood pressure management you care about, leave a comment with your age, your current blood pressure target, and whether your doctor has ever explained the rationale behind that specific number. The answers will tell this community a great deal about how consistently the research is being translated into the clinical conversations that matter. If this video gave you something genuinely useful, please hit like. Share it with someone over 60 who has been told their blood pressure number without ever being told why that number, and not a different one, is the right target for their specific body. Subscribe for weekly research-backed content on navigating cardiovascular health after 60, with the evidence you deserve to have before the decisions that affect your life most. Your blood pressure is a number. Your health is a life. Make sure the number is being managed in the service of the life, not the other way around.